Welcome back, dear students. You've returned to learn about an unwelcome topic, epithelial ovarian cancer. And even though it is unwelcome, this education about it is not. This is an entire unit on epithelial ovarian cancer. It began with video number 413, and this is video number 440, the 28th video in the unit. Thus far, you have learned all about the anatomy of your ovaries, the different kinds of ovarian cancer, the risk factors for epithelial ovarian cancer, the symptoms of epithelial ovarian cancer, the diagnosis of epithelial ovarian cancer, and the treatment of epithelial ovarian cancer. All of that has led you to the understanding that this is a very unfair disease for which women do not fare well overall. Another term for how one fares with a disease is prognosis. And today you will learn the details about the prognosis of epithelial ovarian cancer. This is important because merely saying that women do not fare well tells you nothing about the ways in which they do not fare well. In my book, both the first and the second edition, I don't go into the details of what underlies the failure to fare well with epithelial ovarian cancer, so you need to watch this video for that. Now, the word prognosis can entail many different things. In general, prognosis is the likely course of a disease. But general meanings are never very useful. So let's take the time to really understand the prognosis of epithelial ovarian cancer. And I like to divide prognosis into several distinct parameters. That way you really get a good grasp of what it's like to have this disease and what's likely to happen if you actually get it. So we'll consider all the following for epithelial ovarian cancer: stage at initial diagnosis, treatment of initial disease, response to initial treatment, monitoring for recurrence, diagnosis of recurrence, treatment for recurrence, morbidity and complications of disease or treatment, and survival and mortality. What I'll do is just go through each one of these in chronological order, and that will help you see how this disease plays out in such an unfair way, creating a situation in which women do not fare well at all with it. And as we go along, we'll create a timeline that will put things into perspective for you. So let's start at the very beginning. First is stage at initial diagnosis. In video number 437, you learned that the vast majority, 80% of epithelial ovarian cancers are stage 3 or stage 4 at the time of initial diagnosis. And as with all other cancers we studied, the stage at initial diagnosis is the most important factor determining the prognosis of the disease. The simple unfair fact is that the late stage at diagnosis makes a good prognosis essentially impossible. The basic rule is late arrival equals poor survival. So the 20% of epithelial ovarian cancers that are stage 1 or 2 at the time of initial diagnosis have a fairly good prognosis. The 80% that are stage 3 or 4 at the time of diagnosis have an unfairly poor prognosis. Here's the chart we created in video number 438 on the staging of epithelial ovarian cancer. There you have it. Stages 3 and 4 constitute the vast majority of diagnoses. So let's start our timeline with this information. We're going to start at time 0, right here. And we're going to put stage at initial diagnosis here. And we're going to put stage 3 or 4 right here. So now you see this is what happens at time 0 when you get your first diagnosis. I've just started the timeline, and so what it says is at time 0, when the diagnosis is first made, the cancer is already at stage 3 or 4. Well, stage at diagnosis dictates treatment. So that takes us to the second prognostic factor on our list, treatment of initial disease. In last week's video, you learned that standard treatment for stages 1 through 3 of epithelial ovarian cancer consists of primary debulking or primary cytoreductive surgery, followed by chemotherapy, while treatment of stage 4 involves just chemotherapy without the surgery. Here's the chart we made for that. Now, both surgery and chemotherapy are brutal in terms of enduring the actual treatment. The surgical procedure is quite radical, involving removal of many organs in order to remove as much of the cancer as possible. At all times during the surgery, the surgeon is focusing on the fact that the more cancer that is removed, the better the outcome. More than any other factor, the entire prognosis depends on the quantity of cancer remaining after surgery. So the primary debulking or cytoreductive surgery is a time-consuming, meticulous procedure throughout which there is great attention to detail. And recovery from the surgery is long and slow. Now, chemotherapy usually begins 6 to 10 weeks after the surgery. The goal is to give enough time to heal from the surgery, but not enough time for any remaining cancer to progress. And chemotherapy continues for weeks, months, or indefinitely, depending on the drugs and the regimen. And it's also brutal, primarily in terms of side effects. So let's add this information to our staging chart. First, we have treatment of initial disease, which is going to be right here. And first thing we have is the primary debulking surgery, right? That is here. And then we have chemotherapy, which happens right about there. And we'll put our timeline here at about 6 to 10 weeks. That's about when chemotherapy occurs, okay? We're just building a timeline. Let's stop a minute. I pay attention to the words people and doctors use to communicate. If you listen carefully to words, you can learn as much about what someone is not saying as you can about what they are saying. Last week you learned that the surgery you have at the time of diagnosis can take place either before chemotherapy or after chemotherapy. Well, if it can be before or after, either first or second, why is it called primary debulking or primary cytoreductive surgery? You would think that if it referred to the order of events between the surgery and the chemotherapy, it would be called primary if the surgery is first, and secondary if the surgery is second. But that's not the case. The surgery is called primary debulking surgery or primary cytoreductive surgery, regardless of whether it occurs before or after the chemotherapy. What's going on here? Keep this notion in mind. We'll come back to it a little later in this video. But what about the next word in the name of this surgical procedure? It can be one of two different words, debulking or cytoreductive. What do they mean? The word debulking means removal of as much of the cancer as possible without the expectation of removing all of it. If the goal and expectation were complete removal of all the cancer, the word would be unbulking. So the word bulk means weight. So the real goal, the real expectation is to decrease the weight of the cancer. And cytoreduction merely means reducing the number of cancer cells. It does not mean eradicating all of the cancer cells. Whether you use the word debulking or the word cytoreductive, no surgeon performing the surgery really expects to remove all the cancer. Fortunately, though, the vast majority of women do respond very well to initial treatment. And response to treatment is our third prognostic factor on our list. So let's add response to initial treatment. Unless there are complications from the surgery itself, almost all women respond to initial treatment. But here's another instance in which words matter. There are some hidden pitfalls here. What does the word respond mean to you? Oftentimes, when a doctor says you had a positive response to the treatment, you, as the patient hear, you were cured. But a positive response is not a cure. It is merely a reduction in the quantity of cancer that exists in your body. Of course, you'll have a positive response. All the organs burying the cancer will have been removed or infiltrated with toxic chemotherapeutic drugs. But that does not mean you're cured. So, here we have the response does not equal cure. With most other cancers, your doctor will describe the success of the surgery by using words that designate whether or not all the cancer was removed surgically. Typically, if all the cancer was removed, your doctor will say the margins are clear. Obviously, clear margins indicate that there was no cancer in the outermost rim of the surgically excised tissue. If all the cancer was not removed surgically, your doctor will say the margins were not clear. And that means that the outermost rim of the surgically excised tissue contained some cancer cells. Use of the term clear margins is, well, clear. It's self-explanatory. Such is not the case with the word response. It's much more vague. So be sure to ask your doctor what he or she means by the word response. Last week, you learned that there are categories for how much cancer remains after the surgery. Once again, it's a matter of terminology that is very different for epithelial ovarian cancer than for other cancers. A complete resection means there is no cancer remaining. Optimal cytoreduction means that there is 10 millimeters or less cancer remaining. Suboptimal cytoreduction means there is more than 10 millimeters of cancer remaining. So the terms primary debulking surgery and primary cytoreductive surgery designate the goal of the surgery, but they do not designate the specific procedure. What really matters is how much cancer remains after the surgery. And now you see that clear margins are not the expectation at all. Instead, the expectation is that there will be cancer remaining after the surgery. Yet, you will have responded because there is less than there was initially. So when your initial treatment is complete, you will probably have a disease-free period of time during which no cancer is detectable by any available testing. So that's the disease-free period. That's what comes next after the treatment. So that brings us to the fourth prognostic factor, which is monitoring for recurrence. We're going to put that right here. If you recall video number 434, you learned that symptoms of epithelial ovarian cancer are vague GI and GU symptoms rather than GYN symptoms. And that was back before the surgery when you still had all your original organs in place. Now, after having had extensive surgery, symptoms of recurrence can be even more nondescript or bizarre. So symptoms aren't any more reliable as a means of monitoring for recurrence than they are for indicating presence of the disease in the first place. Then, in video number 435, you learned that there are no worthy screening tests for epithelial ovarian cancer that can reliably detect the disease at an early stage. Well, nothing has changed in terms of the inability of those tests to detect new or recurrent ovarian cancer, epithelial or otherwise. And because you have now had one ovarian cancer, you are at increased risk for getting other ovarian cancers. That's why a previous history of ovarian cancer is a risk factor for epithelial ovarian cancer. But in video number 436, you learned about risk assessment tools for epithelial ovarian cancer. And while these were not adequate for purposes of detecting the disease, they were adequate for determining which ovarian swellings are most likely to be malignant. And their greatest utility is in monitoring for recurrent epithelial ovarian cancer. By knowing your baseline values of various biomarkers for a cancer, you can easily monitor for changes characteristic for return of that specific kind of cancer. So any of the following biomarkers may be useful in monitoring for recurrence: CA125, transthyretin, apolipoprotein A1, beta-2 microglobulin, transferrin, and HE4. And these are used in conjunction with sophisticated imaging techniques. So once you achieve the disease-free period, you will continue to undergo regular surveillance with these biomarkers for recurrence of the cancer. So here we have biomarkers, and we're going to put that right here on our timeline. And that brings us to the fifth prognostic factor, which is diagnosis of recurrent disease. That's this. It's coming along just fine, don't you think? We're just building our timeline beautifully. Unfortunately, recurrence is the most common occurrence. It is not only common, it's expected. It's the norm. It is part of the typical sequence of events for all women with stage 2, 3, or 4 epithelial ovarian cancer. The only women who routinely escape recurrence are the 5% that are at stage 1 at the time of diagnosis. So now you see why some of the words medical professionals use for epithelial ovarian cancer are significantly different from the words used for most other cancers. Medical professionals use the word response because they do not expect clear margins. They use the phrase disease-free period because they do not expect a cure. And because they expect a recurrence after disease-free periods, the so-called response is temporary. Unfortunately, most doctors do not clearly explain that recurrence is part of the typical sequence of events for epithelial ovarian cancer. They tell you that you had a positive response to the initial treatment, but they don't tell you to brace yourself for a recurrence. This is unfair. You have a right to know in advance if you are only expected to fare well for a short time rather than forever. But what's this time frame here between the beginning of the disease-free period and the diagnosis of a recurrence? Notice that I haven't designated a timeline or time frame here on our timeline. This is one of the most important things to know about epithelial ovarian cancer. How long is this disease-free period? Well, it's not years. It's merely months. Quite commonly, it's only about 4 to 6 months. So I'm going to put that on here. Like that. So after enduring a huge surgical procedure and brutal chemotherapy, with what your doctor calls a positive response, the cancer is usually back in a period of just 6 months. That's horrible. The sixth prognostic factor is treatment for recurrent cancer. So here we have treatment for recurrence. Recurrent epithelial ovarian cancers are divided into 2 groups, and these groups depend on the time frame since initial treatment here. And because 6 months is the typical time for a recurrence, the treatment centers around this 6-month point in time. Here's how it works. If diagnosis of your recurrence occurs more than 6 months after initial treatment, you are classified as platinum sensitive. This means that you responded favorably to the standard chemotherapy that includes cisplatin. If diagnosis of your recurrence occurs less than 6 months after initial treatment, you are classified as platinum insensitive. This means that you responded unfavorably to the standard chemotherapy that includes cisplatin. But notice that both instances are based on just 6 months after initial treatment. 6 months is nothing. At our age, it's just a blink. So you see that the disease-free time frame can be very short indeed. This is what makes epithelial ovarian cancer such a disease of doom. And once a recurrence is present, a second round of treatment begins. It entails the same 2 phases as the initial treatment: a secondary debulking or secondary cytoreductive surgery, and a second regimen of chemotherapy. But again, words matter. Now you see the real reason that the first surgery was called a primary debulking surgery or a primary cytoreductive surgery. It's called primary because there is an absolute expectation that there will be a secondary. And just like the first surgery, the goal and expectation of the second surgery is to remove as much of the cancer as possible. But stop a minute. If you've already had your ovaries, your cervix, your uterus, your fallopian tubes, your appendix, and your omentum removed, what's left? Well, all the other organs in your abdomen and pelvis, other than your reproductive organs, are still there. That's what. Your intestines, your bladder, your liver, your gallbladder, your pancreas. So this secondary surgery removes other organs, partially or entirely, that have become invaded with the cancer. Talk about radical. In the breast cancer unit, I taught you about the radical, supra-radical, and ultra-radical surgeries that were performed for breast cancer back in the 1800s. They left women completely deformed because they involved removal of breasts, lung tissue, ribs, and collarbones. Well, here you have something that amounts to pretty much the same thing. And the reason all these other abdominal and pelvic organs become invaded with epithelial ovarian cancer is because of what I've taught you about the epithelial layer that covers all of them. This cancer-studded serosa covers everything in your abdomen and pelvis. Of course, the cancer is going to spread to all of them if it isn't removed completely during the primary debulking or primary cytoreductive surgery. And then the chemotherapy may involve the same chemotherapy drugs, different chemotherapy drugs, or a combination of the two. And your second round of chemotherapy would take place at some time between about 7 and 9 months after initial diagnosis. So I'm going to add all of this to our timeline here. Here's our secondary debulking surgery. And here's the chemotherapy. And this is going to all happen right at about the 7-month mark. But again, using essentially the same options a second time doesn't produce different results. That goes back to the phenomenon of 2 wrongs don't make a right. Well, after the initial treatment, there was this disease-free period of time. But you learned that it was very short-lived. And here we are again after repeating the whole gamut of brutal treatments. So naturally, you'd expect another disease-free period of time, right? Well, you do get another disease-free period of time. But how long does it last? The first one lasted only 6 months. How long do you think the second one lasts? Not long at all. It's even shorter than the first one. Treatment for recurrence is almost never as successful as treatment for the initial disease. And it results in a disease-free period of time of only about 3 months on average. So now we have this disease-free period. And for time, we're going to put months here, and this is at about 3 more months. I know this tutorial is getting more and more depressing, and it should, because this is precisely how the actual disease plays out. The 7th prognostic factor is morbidity, or complications of disease or treatment. That's this. So we're going to put morbidity right about here. And this is all about quality of life. We are talking about a cancer that is advanced at the time of diagnosis with a dismal survival rate to begin with. We are treating it with an extensive surgical procedure from which recovery is extremely difficult. We are following the surgery with brutal chemotherapy that makes you terribly sick. And all that is likely to free you of disease for merely a period of a few short months, with a recurrence being the norm. So you go through all that again with only a 3-month disease-free survival afterward. It really boils down to an investment of all your time enduring treatments which make you feel terrible. It's months and months of suffering. So much of the morbidity comes from the treatment itself. You really have to weigh the benefits of treatment against the risks of treatment. And it may just come down to choosing palliative therapy rather than intensive therapy. So, let's put our suffering here. And this is about at the 10-month mark. Finally, our 8th prognostic factor is survival and mortality. We're going to put that at the very end. Statistics on survival and mortality rates for cancers are usually expressed as 5-year survival rates. 5-year survival rates refer to how many women are still alive 5 years after their initial diagnosis. So reflecting on the fact that epithelial ovarian cancer commonly recurs even within 6 months after the initial diagnosis, how many women with the disease are still alive 5 years after their initial diagnosis? Here are the figures for epithelial ovarian cancer added to our staging chart. So, the 5-year survival rate for stage 1 is 85%. For stage 2, it's 70%. For stage 3, it's only 25%. And for stage 4, it's a dismal 15%. So only 15 to 25% of women diagnosed at stages 3 or 4 are still alive 5 years after the initial diagnosis. So I'm going to put that here, and we're talking about our 5 years here. I've given you the 5-year survival figures for every cancer we've studied, and if we compare these survival rates to all the other cancers we've studied, we get this. Here you see that the actual 5-year survival figures are really dismal for both cervical cancer and epithelial ovarian cancer. The big difference is that we routinely diagnose cervical cancer in the pre-cancerous stage. So we hardly ever see any of the actual cancer. But it's just the opposite for epithelial ovarian cancer. We never diagnose it in the pre-cancerous stage. And we almost always diagnose it at stage 3 or stage 4. And it's all because of that saran wrap. So the overall survival for epithelial ovarian cancer is absolutely horrible. Here's a comparison of overall survival for all of these cancers. The mortality of epithelial ovarian cancer exceeds that of most cancers, gynecologic or otherwise. It is not fair that women with this disease do not fare well. The typical overall course is late diagnosis, treatment, recurrence, retreatment, and eventual death from the disease. The timelines differ, but the overall outcomes really do not. This is one of the worst timelines for any cancer. And that's about all I can take. This is where I'll stop today. The summary is that the prognosis for epithelial ovarian cancer is very poor due to late stage at initial diagnosis, routine tendency for recurrence, and low 5-year survival rates. And I am sorry that I have to present such dismal doomsday tutorials sometimes. I only do so because this is a real education. And a real education includes everything, good and bad. One of the biggest problems with ignorance is the desire to hear only what you want to hear, or to sugarcoat things to make them more appealing. I won't do that. I will tell you the whole truth and the whole story, regardless of whether or not it's what you want to hear. You may use the information as you please, but never wonder if I'm telling you the truth. And next week, we'll segue away from this heavy stuff and discuss the pathology of epithelial ovarian cancer from a perspective that will be very beneficial for you, regardless of whether or not you are at high risk for it. If you want to do something pleasant, schedule a consultation with me at menopausetailor.me. That will improve your quality of life by leaps and bounds and in ways that will last for the rest of your life. Another positive move is to subscribe here to both my channel and my newsletter. And if you just want instantaneous, short-lived joy, follow me on Facebook, Instagram, Twitter, and TikTok. Farewell, my friends, and